I thank AIOS for giving me this opportunity. So I'm Dr. Anusha Ajwani, Director and Consultant at Ajwani Eye Hospital, Bhopal, and I'll be speaking about post-Lasik epithelial ingrowth, its causes, clinical features, prevention, and management. So epithelial ingrowth is basically the presence of epithelium in an area where it does not belong, and after LASIK, it occurs in the interface between the flap and the stromal bed of the patient's cornea. Its incidence following primary LASIK is very low, estimated between 0 to 3.9%. However, it increases when the flap is lifted for retreatment or enhancement, ranging from 1.7% to 23.3%. So the corneal epithelial cells can be introduced into the interface in two ways. Firstly, during the microkeratome pass or other parts of the procedure, and secondly, due to loss of contact inhibition and the presence of a pathway to the interface. Coming to the risk factors of epithelial ingrowth following LASIK, these can be classified as non-modifiable and modifiable risk factors. So the non-modifiable risk factors include patient factors such as corneal epithelial basement membrane dystrophy, history of recurrent corneal erosions, type 1 diabetes, older age group. Hyperopic LASIK is at a higher risk as compared to myopic LASIK. Apart from that, microkeratome assisted LASIK is at a higher risk as compared to femtosecond LASIK. Prolonged manipulation of the flap and excessive instrumentation at the interface, partial flaps, flap misalignment or dislocation. Surgical technique used can also can be a risk factor, and direct flap lift with forceps is at a higher risk as compared to cleaving with spatula before lifting, corneal epithelial injury, buttonholes, and spillover of ablation at the bed margin. So based on the location, clinical features, and severity, PLEI can be classified into 4 grades using the Provost-Machart classification. And this classification serves as a useful aid for consistent and standardized grading and provides guidance on the treatment strategies. So in this grade 1, there is a thin growth with a well-delineated white line along the advancing edge with no flap change. The location is 2 mm within the flap edge and no treatment is required. In grade 2, there is a thicker growth, no demarcation line along the nest. There can be presence of rolled or gray flap edge with no melt. It is located 2 mm within the flap edge and no urgent treatment is needed. In grade 3, there is pronounced growth. There can be opaque ingrowth with geographic areas of necrosis with no demarcation line, and it is located more than 2 mm from the flap edge and treatment is needed. In grade 4, there is aggressive growth which can result in flap melt, threatening or affecting the visual axis and requires urgent treatment. So coming to the prevention, to avoid epithelial ingrowth, patient selection is very important. Patients with the stated risk factors may achieve better results with PRK than with LASIK, thus avoiding the possibility of epithelial ingrowth. We need to avoid prolonged manipulation of the flap, clear an epithelium, tags or debris from the stromal bed prior to flap repositioning, apply BCL when epithelial defects are observed, and it's always a good idea to use new blades with minimal and careful use of topical anesthesia. Coming to the management, for mild and non-progressive epithelial ingrowth, that is grade 1, no treatment is required. We need to carefully observe the patients to ensure that the growth is not progressing. Intervention is needed only when ingrowth appears to be progressing, affecting the visual acuity or causing flap melt. So the most common treatment strategy for PLEI is mechanical debridement of epithelial ingrowth from the flap stromal interface and from the inner side of the flap, followed by careful repositioning of the flap and avoidance of any intraoperative or postoperative epithelial trauma. It is a good idea to resect the epithelium from around the flap bed. Use balanced salt solution to irrigate the interface, the flap, and the stromal bed to ensure removal of all the epithelial cells. Then tightly replace the flap, followed by placing a BCL. Flap suturing, fibrin glue, and ocular hydrogen sealant at the flap edge have been proposed to facilitate secured flap adhesion. Apart from that, in refractory cases, adjunctive therapies such as ethanol mitomycin C can be used to help eradicate PLEI. Amniotic membrane grafting may be used in cases associated with flap injury or melting, And in severe ingrowth with melting and folds, it is better to remove the flap and allow for healing. Use of ND-YOG laser has also been reported as a novel technique for treating PLEI. ND-YOG laser produces short individual pulses of focused infrared light, 30 to 40 pulses of low energy beam focus slightly posterior with respect to the epithelial ingrowth starting in the center. The power is adjusted to the minimal amount to form bubbles. At the margin of each bubble, new spots of laser are shot until the entire area of epithelial ingrowth is treated, sufficient enough for blocking progression and to decrease the size of ingrowth. So in image A, here we see that there is epithelial ingrowth at the interface. In image B, that is at 1 month after first session of ND-YOG laser treatment, epithelial ingrowth has well-defined borders. In image C, it is at 1 month after second session of YOG laser. Epithelial ingrowth has further decreased in size and density. And image D, that is 2 years later of ND-YOG laser, demonstrates minimal scarring in the interface at the site of previous ingrowth. However, ND-YOG laser itself has certain complications and can result in localized flap melt and flap surface breakthrough, with the creation of new channel at the flap edge, resulting in new areas of epithelial ingrowth. So the recurrence rate following treatment depends on the treatment strategy, and follow-up duration ranged between 0 to 44% due to improper adhesion of flap. Mechanical debridement of both the interface and inner aspect of the flap, followed by application of fibrin glue, appears to have the lowest recurrence rate of PLEI as compared to other treatment modalities. So to conclude, with the continuing rise of Lasik procedures, it is important for ophthalmologists to become competent in recognizing and managing the post-Lasik complications, including PLEI. Understanding of risk factors helps to reduce the incidence and also enables better patient counseling. And when appropriately managed, good visual prognosis is usually achieved. Thank you so much.